Good morning, good afternoon, good evening. Warm welcome to today's webinar on the big picture on worldwide massive aging. During the session, we will look at the massive aging of the population, which is clearly amongst the most significant world healthcare challenges over the first part of this millennium. The webinar intends to share a vision on the size and the consequences of this worldwide incredible impact of massive aging on healthcare organization and processes, especially for quality and safety aspects. We're delighted to welcome today's presenter, Dr. René Amalberti, who is Professor of Medicine, Physiopathology, and Cognitive Psychology. After residency in psychiatry, he joined the Air Force in 1977, graduated in aerospace medicine, and got a permanent military research position in 1982. Professor Amalberti retired with the rank of general in late 2007. During his career, he occupied several detached managerial positions in national and international bodies, had human factors and flight safety of the European civil authorities. He was the chairman of the French National Program Road and Railway Safety and the chairman of several scientific boards in charge of environmental risk. Just to remind you that today's presentation will take approximately 5 minutes and we'll have 15 minutes for the questions. You will be able to ask questions by either typing your question in the chat box provided or by raising your hand. If you do raise your hand, your mic will be unmuted and you will be able to ask your question live. Please do make sure that your mic is connected before you raise your hand. We also will be using polls during this presentation and would really appreciate your active participation. Now, without further ado, over to Professor Amalberti for the presentation. Over to you, René.
Good morning or good afternoon, everybody. I'm very pleased to introduce this first webinar on the massive aging. It is the first webinar. We shut off a second webinar in September, and today we are focusing on the big picture and sharing vision on the consequences of this incredible change in the society. Of course, ISQua is really pushing in this direction, and the Innovation and System Change Working Group of ISQua is carrying out projects assessing how health system can cope with the consequence of population aging. We must understand that simply allowing a population to age without having a plan for how to deal with is not enough. The number of people aged 60 or more will increase from 900 million this year to 2 billion in 2050. And that is, for example, more than a 50% probability that by 2030, national UK female life expectancy will break the 90 years barriers, etc., etc. And it's incredible also to say that by 2020, which is just in a few years, individuals aged 60 or more will be more numerous than children under the age of 5. So maybe just before entering into more detail, can I ask you, René, to ask you two general questions on your vision of the problem. René?
Thank you, Professor Amalberti. The poll is now launched, so we would like to seek your opinion on the following question. Do you consider that massive aging is a concern for your country? Just two options for you to choose from. Yes and no. We can see that our participants are already voting. So just we will give you a couple of more seconds before we are displaying the results. The responses are significantly going one way. Was 82% so far saying that the massive aging is definitely a concern for their country. But just let's wait a couple of more seconds before the final results are displayed. So let's just see what our participants think and what's their concern. And it's very close to what I have already announced. 83% of participants do think that massive aging is a concern in their country, but 17% have opted for the answer no. Over to you, René. Would you like me to launch the second poll straight away?
Yeah, the second question now.
Okay, and now let's just go straight away to the second question. And as you can see, we would like to know, have you already started, or have your country already started any initiatives to address the issue of massive aging in your country? So again, if you don't know, just choose no for a moment, and then we will see how that goes. So this time the participants' answers do are spread out across the two options, so we will just give them a couple of more seconds before we display the results. Okay, so let's see what our participants think. And 69% of our participants have reported that either themselves or their country have already started to address the issue of massive aging, while 31% went for the option no, so it means that hasn't been addressed in their country. Over to you, René.
Yeah, thank you. So we see that many people are really aware that it is a problem. There's a little gap between being aware and starting doing things. So if we want to understand a little bit better what occurs, it is just a worldwide context to see that we have an increasing population with the baby boomers aging, benefiting from a generation of peacetime, improved living condition, more access to care, reduced infant mortality, and biomedical science. And in a way, we are a kind of factory of creating patients that survive to acute disease that should have killed them within a period of 3 months to 1 year in the 90s. So we permit people to survive to acute disease. They are aging with their disease. Of course, they are aging with comorbidities, and the result is that if we look at global, at the big picture, this is a picture from Global Age Watch dated 2015 with the projection at 2050, and you see that most of the world will become red, which means over 60, and you see that as I said before, the people age below 5 will progressively be less numerous than the people age over 65. And when we look at the detail of the country, what is quite important is to see that all countries are concerned with the problem. Some are not with the problem today, are through the Japan, Spain, Portugal, Greece, and the top of the table have already a significant amount of their population over 60. But what you see is that even for countries who have today not a large fraction of their population above 60, they will become rapidly aging, and this is quite important because it means that the problem is not limited to rich countries, absolutely not limited to rich countries. It is even worse. The poor countries or the low and middle income countries will age much more in comparison than the rich countries because of the benefits of the accumulated benefits of medicine and different factors that are very contributive to aging. the problem will be much more sensitive in 2030 and 2050 for the poor country than for the rich country, which really turned the problem kind of different to the many problems we have seen in the past. It's a world problem, and you see that in 2040, the distribution of countries by phase in age transition will give a predominance of people over 60s compared to the other class of the population. This, of course, is extremely consequential for many aspects of social, political, and medical life. First, for the economy, it's an incredible economic burden for nations. Of course, there's a risk of poverty among the elderly because the retirement will, even it comes later, will reduce the finance of these people, the income of these people, and they will be in great trouble for aging. There are, of course, also generational equity problems, and there's a growing impact on retirement time. In the Western countries, we are progressively moving to 62, then 65. Now we have many countries at 67, and probably we would have retirement time over 70 in some countries within 5 years. It has an impact on work and family, incredible impact on work and family. And we used to say that when 4 generations are living in parallel, there is no more capacity of heritage for the younger. The older will use all their income and finance and capacities and loans, and they will be unable to give money to the youngest. The reduction in the number of workers is also a problem because they are supporting consumers, and it's very important between now and 2050. There's many unsustainable public transfer system, and of course, aging is by itself a chance. That is also a terrible cost on the medical side, because the end of life in frail patients could represent over 30% of healthcare expenditures, with a peak possibly reaching 50%, especially in Japan. So it's an incredible economic burden, and there's a recent paper published by Standard & Poor's about France, which say that if France is not changing very quickly the healthcare system and the politics about aging, the present notification AA, which is the quotation of France by Standard & Poor's, will become in 2030 BBB. So you see that it is an incredible burden. You see also that maybe it's an opportunity, because you have a fantastic capacity of silver economy behind people aging. And the problem is to turn this capacity into reality and really create employment and use the tech boom for doping, in a way, the economy. And that is not already something totally done, but it is an expectation that it could be a solution to reduce the incredible economic burden. Of course, there's also an incredible medical impact, because, as I said before, people are aging, and people are aging comorbidity because they are surviving acute disease, and they're accumulating acute disease, but they're also accumulating surgeries for the rehabilitation and the healthy aging. And what is expected in 2020 in the Western bloc of countries is that all citizens will have 2 to 6 prostheses at age of 75, dental, eyes, ears, hip, knee, and more. So they will come not just, these people aging will come to the hospital not just for their pathology, but they will come also because they want to have an healthy aging. So the number of people coming to the hospital and to the system will be incredibly increased in the near coming years. It start increasing, but of course it will increase with incredible slope. And of course we have to take into consideration that we have to cope with the loss of autonomy, the growing number of frail patients, and as you see on the various figures, if we start with the figure on the right, you see that the number of disease of Alzheimer's disease and cognitive impairment disease will increase by 3, 5, 10, reaching 10% of the population. And again, what is quite important to understand is that low and middle income countries are paradoxically more concerned than high income countries. It's a relative result, but it's very significant result. So the number of cognitive impaired people will increase in all countries with the need to take care of them, and there are not many solutions, as you may guess. You can expect the families to be aiding, you can expect the system to be in position of aiding, or you can maybe think about our solution, but there are not really many. What you see on the other figure in the center is that, but it's not a surprise, that the public health care expenditure increased by age group to reach a very high amount of money for aging people, especially at the end of life. Because when you are healthy aging at 65 or 70, not necessarily you cost more than today at 55, but when you're approaching or you're really aging and approaching your end of life, then the overcost is terrible. And what you see on the last figure is the disparity of the world population with 3 risk factors. We show also that there are other factors behind the problem of aging. The preeminence of diabetes and cardiologic problems is different from one continent to another, independently to the income, to the level of the society in terms of income. And this also will create a specific burden in some continents, because not only the people will continue aging, but they will continue aging with many risk factors and with an additional medical cost in that case. Of course, we have incredible impact on the organization and the community health. Massive aging asks for a more effective reconsideration of who provides care and support, pointing to the need for a series of new actors. You cannot just bet on doctors in hospitals or nurses in hospital. Now you have to really bet on social actors, communities, support persons, and families, because all these people aging are at home for the vast majority. They cannot stay at the hospital for a long period of time, and for this reason, the organization of the healthcare at home is quite central in the future success for dealing with this community of people. It requires a profound organization change in healthcare, integrating long-term care within primary and home care. Of course, because people are aging for decades, for 20 years, 30 years, and it's a very long shot. It's not just acute medicine, it's chronic medicine which is taking the lead. And it necessitates, because you put people at home, to adapt housing, mobility. So it goes much beyond the strict medical problems. You really need to reorganize the living areas in order to be compatible with autonomy of people aging, and you need, for example, to have buses, to have systems who are really compatible with these people. And the problem of isolation is very central. If we just continue the domino effect, it's clear that we have more patients. As I said, we're creating patients with the excellence of medicine. We're permitting patients to age because they are surviving to acute disease. So we have more comorbid patients necessarily asking for more care. And fortunately, because it costs so much, as we have seen, one of the solutions that is proposed everywhere in the world is to make a balance between the hospital and the primary care, and to organize, thanks to the capacity, the technology, the fact that patients are spending less and less time in acute care settings. For example, the minimally invasive surgery is a day surgery, so you don't need to keep the patient. You can even consider very difficult surgeries now and just keep the patient either on day surgery or with rapid discharge at day 1 or day 2. And that is a good thing for saving the money, because the hospital is really the location where you spend the most of money. But it asks for a very robust organization behind if you are discharging these acute patients to the rehabilitation structure or to their home. And of course, if you do that, if you reorganize the hospital to reduce the time in acute care settings, if you privilege the early discharge, you will create a cascade of effects on how to reorganize your hospital, because you will trade, in a way, a rapid discharge with an incredible increase of patients coming to the hospital. So you turn the system from a long stay at the hospital to a system of flow. And we know that, for example, that is really provoking a change in the standards for quality and safety. You cannot treat the problem of a high flow of patients like you treat the problem of long stay at the hospital. So maybe it's a good opportunity for first break, asking for a question. Jurana, will you ask people? Are there some questions coming?
There are no questions so far, but I'm sure we will have most of the questions at the end, so we can keep going for now.
Okay. So we see the problem is multifactorial, and the consequences are really on different fields: political, social, economy, and medical. And what is maybe more important is that, of course, we understand that healthcare needs to change and adapt. It is widely recognized that the organization of healthcare will need to increasingly shift with more care delivered in the home and community. But really, the change are much more fundamental. This is just a fact, what you have said. But the problem is that a change is needed in the approach from the aim of healing and restoration to health, which was really guiding the healthcare system for decades, millennia, to a longer-term aim of supporting well-being in the face of chronic disease and increasing frailty. So you move your mind in the way you are addressing problems. So the change also is from a one-size-fits-all approach to something much more personalized, and we need to make this big turn to address personalized treatment of patients. And probably we need to consider a project for aging, which is an individual project of aging based on the accumulation of the disease, previously acute disease and chronic disease, and also based on the reality, the social reality of this person willing to age, isolation or not, capacity of aiding persons and family around this person or not, etc., etc. And pragmatic decisions in terms of effectiveness, quality, and safety must take into consideration the most achievable and relevant outcomes for local aging population and for whose main goal is living a healthy and happy life at home. So we need more and more pragmatism. We cannot have the same vision for all. We have to organize a system really with a project of aging, with, of course, a consideration for the healthcare system in support of this project, but the medical support of the project of aging cannot be alone. It must be coupled with a social project, and this makes the situation a little bit more complex than many other problems we have to address in the healthcare system. And of course, there are very many implications for quality and safety. The goal of healthcare is evolving towards enabling longer and healthier living. But as we have seen, with moving the hospital, especially the acute hospitals, to move from a logic of hospital stays to a just-in-time logic. And when we are addressing just-in-time logic, it means that the patients are not staying a long period of time in the hospital. For many, it will be day surgery or day medicine. And we can consider now that at least in Western country, 85% of the patient will be discharged before day 2 within 2030, which means that the problem for the hospital is to reorganize in consequence to that just-in-time logic. And for example, if you consider a ward, a standard ward, the very problem is maybe you can have staff shortage, but if you consider that you are just with the right staff, the very problem with just-in-time logic is that the patients are changing on each bed every 1 or 2 days, which de facto makes the workload within a week double or triple the workload it is today, because you have only acute patients, never patients recovering, because when they are starting recovering, they are discharged. So it's changing the logic of staffing the hospital. It's changing the logic of controlling adverse event, because the problems are seen behind you by the rehabilitation structure or the primary care. Since the patient has been discharged, quite immediately the problems are discovered for your work must be after they have left the hospital. And of course it creates a series of change in minding how you can address in this adverse events problem, including transparency, because when you are transparent with the patient, you say in that case to the patient that the previous doctor of the previous setting, in general the acute hospital, has been in trouble. And of course this raised ethics problems to say that the others have made errors. So we need to reorganize the way we consider problems, organize the journey, and that is really at the core of this big change. We have to mind the problem of patients in terms of journey, not just in terms of they stay into the hospital or they stay into the rehabilitation structure behind the hospital. And if you can mind the people in terms of journey, you have to adapt all the system on that basis, including probably for morbidity, mortality staff, to invite all the protagonists of the journey, the GP as well as the surgeon or the rehabilitation doctor. And that is very difficult. Now we are in big trouble for doing that. And I have not said what is probably as important as all what I've said before, is that in that journeys, only the patient really have the memory of all what occurred. So it's quite important to turn our mind to ask much more to the patients what type of adverse event they had, because Otherwise, the risk is to lose any vision of problems in the near future. And of course, we will have also to consider specific adverse events at home, which are very different from what we have in the hospital. We have to adapt adverse event analysis, definitively. And we have much more to do. We have to reformulate definition of quality and safety to reflect the realities of care at home and in primary care. Of course, we have to deal with much greater emphasis on patient autonomy and participation, including the strengthening of social skills. Are they able still to drive? Are we in position? Can we bet on the community support to have feedback on their capacity of doing things? I just remember, for example, in the Jönköping county in Sweden, they have taxi drivers who are paid by the at least half of the cost by the government or the community, and they are visiting the aging person at home and just reporting. We have seen these people today; they are quite good. So they report simple things, but this community support is very performing, because if any problems occur, it is immediately known by the monitoring, the central monitoring office, which can send doctors and nurses. So it's really an important impact. We have to develop or revise the quality standards to reflect living well with chronic disease. And as I said before, including 10% of the population who live with dementia. And I just quote what I've heard from Japan. They are now educating their young boys and girls at primary school to live with dementia. They have mandatory program to educate the very young to learn how to live with dementia people. We have to support family members as the primary caregivers, and probably we have to pay them in the future as participants to the journey. But this is, of course, difficult. It's not done at present. We have to adapt quality safety standards to reflect the increasing use of medical information technology and on support. We will not be able to develop this massive living at home without the mobile and the capacity of the very simple capacity of the tech boom, which permit to have connection, medical connection, and social connection with the patients at home and the aging persons. So it's not necessarily very costly, but it's very, very central to very quickly. We have to adapt quality safety standards in terms of access to healthcare, and they must also reflect issues such as the distance and proximity to healthcare, especially for rural or remote areas, which are more and more important in the way you consider aging in your country. And probably you need to introduce some flexibility in quality and safety standards. Again and again, one size cannot fit all. You have to think the problem pragmatically with the doctor you have, the nurses you have, and where the people are living into their village, and organize at best solutions. And you have to assess the implication for evaluation and certification of primary care care. Of course, it is very difficult to do this transition. It's a big leap. It's a big revolution to do. So it will be painful for everybody. You have to explain and prepare professionals for that. You have to explain that we are not changing the healthcare system for the pleasure. We are changing just because we are so excellent that we have created patients, billions of patients, who are aging because they are not dying for their acute disease. And it's a success of healthcare, but the success asks for changing the system, and that is quite important to explain. We have to really simplify and avoid unnecessary added burden, suppress low priority requirements. We have so many that really low priority requirements are not priorities. Clean the system, keep people focused on care, not administration. We have to increase collaboration at all stages with all actors and monitor transitory risk within the spirit of a just culture. We have started changing things. We have already less compliance on acute care. We have sophisticated treatment permitting to the early discharge. We have diagnosis, testing protocols, less invasive treatment, shorter stays at the hospital, or no hospital admission at all. But still, we have a lot of things to do. We need to fund a wider variety of our services: hospital, primary care, home and aged care, rehabilitation, and really that requires a conceptual shift. And this change is very slow at present, not just in low and middle income countries, but also in rich countries, because everybody is concerned about the cost of the reform. And the real change is to balance the needs of the present with those also preparing for the future. But the future is for tomorrow. So we have so many challenges for research. Take opportunity for innovation, digital revolution, reevaluate the quality and safety theories, define a global quality and safety frameworks consistent with the change. And I mentioned the just-in-time logic into the hospital, but many other change at home. Need to broaden training course to educate top and frontline managers to navigate safety, to adapt safety to with pragmatism. And we with Charles Vincent we cited a portfolio of strategies which could be used much more than it is. Of course, there are many challenges for professionals. We have to engage professionals in a challenge of continuity. We have engaged professionals in a much greater partnership with patients and carers, the logic of journeys. We have to engage professionals in much greater relevance of care. And again, educate and teach professionals the laws of navigating safety. And of course, we have challenges for patients. They have to adopt a new partnership approach with citizens, patients, share risk approach, share risk awareness and risk management, and improve risk evaluation, and including adverse event analysis. And last but not least, we have many challenges for authorities. Adapt standards to risk management versus risk suppression. Adapt standards to patient journey versus hospital stay. Develop standards for primary care, home care, and AD persons. Adapt accreditation process to the fragmentation of care and patient journey. And adapt the authorization regime to the variety of context and setting. So what is the challenge for ISQua? We started working on, well, first there are many contributory works already published on massive aging by the WHO, the United Nations, the OECD, and more. So it's clearly a problem that is addressed by many. But the focus of ISQua is complementary to these approaches. We really focus on the worldwide impact of aging on healthcare organization, quality and safety standard. And that's done that much by all the bodies I've cited before. We started in 2015 at Doha. We continued in 2016. We have published paper and a white paper that you can download easily. And now we are engaged with this webinar on an information on the global scale of the problem. A second webinar coming September on the solution space. And we want to really focus in the near future on an atlas of solution for quality and safety change. What are the consequences for quality and safety of massive aging? And a collective book. And really I hand on about that because it's a great opportunity for you to join us at the ISQua conference in London and participate in constructing the future of quality and safety in healthcare. And the pre-conference is for the 1st October on the morning in room 1. So thank you for your listening, and maybe you have questions.
Thank you, Professor Amalberti. We do have a couple of questions. We'll start from the comments first, and the comments from Marianne Street. She's thanking you for your presentation and your comments in particular, where you have been addressing the need to be a change in healthcare due to increases in chronic diseases and acuity of patients. They have recently completed a study of patients in a sub-acute care who deteriorate clinically and require transfer to acute care, which has implications both for quality care and economic cost to the health service. So she's definitely confirming what you've been saying, that some patients are discharged from acute care too quickly and sent to subacute care, but then deteriorate. I'm not sure whether you'd like to further comment on that, but that's just a long message from Marianne Street there for you.
It's a very big problem, and we have to be in control and learn from the criteria for discharge and the criteria for inclusion for day surgery, for example, much more than we do today, because once we have whole the system working in that direction with these principles, the logic of just in time become a very difficult logic to control and maintain at the highest performing level. So yes, it's quite important to have this criteria in mind and do better than we do today, but we are still learning on that problem.
Thank you, Professor Amalberti. So the next question is from Ismaila Gray, but just to remind the remainder of our participants, if you do have any questions, there is still time to type them into the question or chat box provided, and we will have an opportunity to ask Professor Amalberti to respond to them. So the next question is from Ismaila Gray, and she says, in developing countries, the healthcare delivering and is growing rapidly, but the level of human and material resources is not up to standard. How can the quality safety be provided if that is the case?
Probably there's no magic solution. If you have really a lack of resources, you're in trouble for doing your best. But nevertheless, you can balance this relative scarcity of tools with the quality of aiding persons and family. So in many developing countries, this point is still an advantage compared to the Western countries. The aiding person, the proximity community is provided we have educated a little bit this proximity community is able to compensate many of the tools missing, and if you have this capacity of maintaining the proximity community in this aiding attitude, you will probably be able to have good results despite of the limited capacity of tools. Then it is also true that many tools developed in Western countries are unaffordable for low and middle income countries. But if I think about some tools like the mobile, it is clearly a tool that should be massively developed in these developing countries, and which may reduce many of the problems we have today by giving capacity of surveillance and monitoring and reduction of isolation context.
Thank you, Professor Amalberti. The next question is, are there any leading countries that have already been addressing the issues of massive aging and can share their lessons learned so they can be adopted worldwide?
It is yes and no. First, it is yes, they have started considering the problem. They have done little in comparison to their capacity. As I mentioned before, the problem is that most of the decisions asked for are very costly. And even in Western country, spending the money too early is a risk to be not really understood by the citizens. So many of the rich countries have the plan ready to go, but not really implemented, or just they have experimentation here and there, but not a national plan. But is not deployed at present. That's one point. The second point is, should we consider that the solution is the same for everybody, and that there are champions, especially the richer country, the richest country I'm not sure that, because many solutions, and I go back to the previous question, many solutions developed by the richest country will not be able to be transferred to low and middle income countries. So I would take some distance from considering the richest countries as the champions. There are probably several solutions of champions, and the best, and that's really what we try to address in the ISQua approach, is to capture where are the champions, but not the champions just as a matter of putting more money on the problem, but the champions are in the way they are reorganizing their system with the pragmatism of their economy and capacity, and with this big capacity, local capacity, they obtain significant results. So I don't think there are one champion. There's one champion. There are probably many from different type of countries, and that's really what we try to capture. And yes, once we have these different champions, you can try to copy the champions who are a little bit big brothers, or how to say that, close enough to your country.
Thank you, Professor Amalberti. The next question is ISQua planning to develop set of recommendations to deal with massive aging at some point to guide the countries?
Yes, we have two action in mind. First, I said we are focusing on quality and safety consequences, not on social or political issues. This is well done by others. And for quality and safety impact, we have a series of recommendations what we intend to develop for moving the healthcare system and adapting the healthcare system globally, including the ethics and the way the system is dealing with patient journey. And then we have some local recommendation for quality and safety in just-in-time logic for hospitals, and quality and safety recommendation at home. So that's the program of ISQua for this year, next year, and again and again we expect you will join us for developing and extending this program, because all these recommendation needs to be really shared and for some tested into different settings.
Thank you, Professor Amalberti. The next question is ISQua planning to develop standards on massive aging to be included as part of the accreditation process in order to address massive aging?
Yeah, it's clearly one of the central topic. You know that ISQua is developing a big program for accreditation, and accreditation must move because of the fragmentation of the system and patient journey. So the move of accreditation to patient journey has started, but started slowly. And clearly, massive aging is an opportunity to re-question and develop a standard for patient journey, the accreditation of patient journey. We will develop the recommendation in that direction clearly. Yes.
Thank you, Professor Amalberti. The next question is from Hanoko Basula, and the question is as follows. In developing countries, there is an acute shortage of formal health infrastructure. Primary care is sporadic and randomly distributed. On the other hand, families themselves struggle financially and have limited ability to be primary caregivers. How to deal with this limited quality access and funds situation in developing countries where aging population is going to be increasingly burdensome in the future?
That's a good question, and again, I have not magic bullet for answering the question. Although, as I mentioned before, it's true that doctors are missing, and that many structures that make the problem affordable in other countries are difficult in these poor countries. But again, the solution may come from the proximity care, developing nurses, well, training nurses and training ailing persons and families to live with the elderly, and in a way doing the change progressively by keeping the hospital probably more more in the line of structure of stay, reducing progressively, but not turning very quickly to just-in-time hospitals. So because the mass of the professionals are into hospitals in these countries, keeping the hospitals as central area, but then spreading nurses and ailing persons with mobile support to all the territory and to the proximity is probably a solution. And it's not a magic solution, but it's part of the solution to have this low-cost proximity community as a relay in dealing with the aging problem. And it's feasible. It's not magic, but it's feasible. And probably it also there's another point. When people will be massively aging in these countries, which is probably within 20 years or 15 to 20 years for most, the pressure from this class of the society will create the needs for moving a little bit more quickly the organization. So maybe these countries will wait for the pressure from the people, for the patients and from the citizen, because they have not a problem today, really. And that's another obstacle. Try to move the organization when you have not the problem. Either you are certain the problem is coming. When you are not facing the wall, you are reluctant to reorganize things. But within 10 years, in most of these countries, the problem will become a reality, and that will probably increase the need for finding out solutions. Again and again, mobile and proximity community may solve part of the problem. Low-cost solutions.
Thank you, Professor Amalberti. And the next question is that during your presentation, you have mentioned that we need to adapt adverse event analysis. Is there any insight of how this can be done?
Yeah, we have some ideas coming, and papers submitted with Charles Ensign, so I cannot cite this paper, but I hope it will be available soon. So yes, we are covering the problem. We need to move. If I try to summarize what we have to do, first, I mentioned that we are moving to patient journey. So we have to really consider a wider period of time when we are analyzing adverse event, not just considering the day before, but really the logic of the episode of care, the patient journey. The second point is that most of the problems we will not be aware of them because the patient journey is fragmenting care. So the patients are more and more necessary to capture this adverse event, and probably we will need to have a specific approach for asking patients to report much more than they are doing today their adverse event, maybe systematic questionnaire or things like that, to identify problems that are escaping the logic of the short vision we have in this fragmented system during the patient journey. The third point, which is very, very central, is that as we have a big shift between healing and just having a healthy life, it is quite important to consider that the future of adverse event is much more to consider how we have recovery and mitigate problems than their cause. So searching for cause is just a limited part of what we have to do in the future for adverse event. Since there are adverse events that move on a long period of time, it's quite important to understand how the system is able to detect them, to recover from them, and to mitigate from them. And the safety of the system will be much more associated with the failure to recover, the failure to really deal with problems occurring than the suppression of causes. So yes, we will continue searching for causes, but we will add significant focus on the recovery and mitigating problem all along the patient journey. That's 3 points that really ask to be changed in the near future to adapt adverse event analysis to this massive aging phenomenon.
Thank you. And the last question for today so far, have you considered in your paper the impact of the cultural aspect on massive aging and the way countries have already started or planning to deal with the issue? So
Sure.
impact of culture.
Yeah, it's clearly one of the direction we want to investigate into the ISQua conferences and ISQua work on the domain. We want to, as I said and said again, one size cannot fits all in that matter. There are cultural issues behind. There are also economic issues. So we have to map these differences worldwide and try to understand what are the best solutions for different system of culture. Not make judgment on it is good or bad culture, but understand the pragmatism of each culture and the way it can lead to solutions, specific solutions, and show this solution in the Atlas of Solution in the book that is in preparation.
Thank you, Professor Amalberti. I think at this point of time, we have no further questions, and I would like to thank you for delivering this webinar and leading ISQua's directions in terms of dealing with massive aging together with a number of other contributors. So thank you so much for sharing your expertise with us today and starting the conversation. Just to remind the participants that this is only the first part of the series of the webinars. The next one is going to be on the 19th of September, and the conversation will continue at the ISQua conference in October. So you're all welcome. You're all welcome to attend the next session as well as the conference session. And well, thank you everybody for attending today. And once again, Professor Amalberti, thank you for delivering the session.
Thank you. Bye-bye, everybody.